Right. We go to the second part of your question.
Yes, sir.
Golden hour.
Yes, sir. The second topic is on the golden hour in trauma. Here, the definition, to start with the definition, the golden hour refers to the first 60 minutes following a traumatic injury, during which rapid assessment, resuscitation, and definitive care are most crucial to prevent the death and disability of the patient. The rationale here is every trauma deaths are preventable causes such as the airway obstruction, tension pneumothorax, exsanguination, and severe brain injury. Delay in intervention leads to hypoxia, acidosis, and cellular death. Early resuscitation and transport reduce the mortality by up to 30 to 40%. The physiological basis here include the hemorrhagic shock, where early correction prevents irreversible phase of shock, hypoxia, where the prompt airway and breathing management prevents secondary brain injuries, and the perfusion, if timely fluid or blood replacement given, maintains the organ perfusion and also prevent MODs. The objectives of the golden hour is to rapid identification of life-threatening injuries, early airway and circulation control, rapid transport to a definitive trauma center, and also initiate definitive care, whether it includes surgery, transfusion, or any neuro intervention. So the phases of care during the golden hour include the pre-hospital phase, which should be around 0 to 10 minutes, where the key actions include scene safety, triage, airway control, bleeding control, and also spinal precautions. The second is the transport phase, where it is the 10 to 30 minutes. Here, the oxygenation, IV fluids, and blood monitoring and rapid transfer should be done. Third one is the hospital phase or the ED phase, where 30 minutes to 60 minutes happens. Here, the primary survey, the airway ABCDE, and then the resuscitation, also imaging or any surgical decision has to be made. And then the last phase is the definitive phase, which should be usually less than an hour, ideally, where any surgical or ICU care or a hemorrhage control, also any organ support has to be done. The primary survey, according to the ATLS guidelines, include the A, which includes for the ABCDE, where the A is for airway with cervical spine protection. B is going to be the breathing and ventilation. C is for circulation with any hemorrhagic control. D is going to be the disability, where we assess the neurological status and the GCS of the patients. E is going to be the exposure with environmental control to prevent hypothermia. And there are adjuncts to the primary survey, which can be the FAST or the E-FAST ultrasound, any chest or pelvic X-rays, baseline labs, and cross-matching has to be done. The secondary survey, here the detailed head-to-toe examination has to happen after the stabilization and identification of any occult injuries. The key principles here are time crucial intervention, which can improve survival, early transfer to the trauma centers, reduce the preventable deaths, and multidisciplinary coordination, where the pre-hospital ED, OR, or ICU is essential, and minimal on-scene time, where scoop and run policy has to be maintained. Thank you, sir.
That?
Yes, sir.
Without wasting time, I'll just do what I have to say. So, golden hour in trauma management, all of you know that say hour, you say 60 minutes, 1 hour. So the first 60 minutes of trauma injury is most crucial period. It determines the ultimate outcome. What are the three categories of patients you have come across in trauma? And to which category this golden hour is applicable?
Sir, the stable trauma patients, sir. Stable trauma patients or unstable, potentially unstable trauma patients, and critically trauma patients, sir.
So there are three groups of trauma patients. First group, they immediately die at the site of accident or trauma itself, because the injuries are so severe, like penetrating cardiac injury or a severe major hemorrhage because of the direct injury to the major blood vessels. So these patients don't require any, we cannot apply this 60 minutes or first golden hour rule to them. The other extreme category in the spectrum is those who have multiple fractures but no overt loss of blood or no injury to the cardiovascular or respiratory system, who just require some pain relief and immobilization of the fractures, who are hemodynamically stable. They are patients who can be triaged and kept waiting to be transported at a little leisure. But the second category, or the category in between these two extremes, one is the one dying immediately, the other one with a stable but multiple injuries. The middle category is the one who have life-threatening injuries, and unless you immediately salvage them, they can either immediately die, or the consequences of the injury are going to cause them problem later on also. So these are the three peaks they call first peak, second peak, and third peak. And it is the second peak which requires the concept of golden hour management. So the main steps in the early management are, of course, earlier it was called primary survey. And they have changed the name to primary assessment and resuscitation, which should be performed together, especially airway breathing circulation, ABC survey. This terminology we use not only in trauma but also in other major critical incidences where the exam you have to say, I will first make, for example, a burns patient. You have to first say, I will make a ABC survey, because all the burns also comes under part of the trauma. And then later on only, or if the time permits, you can do the secondary survey also within that 60 minutes. And it provides the basic data essential for patient survival when life or limb is threatened. And the secondary assessment performed after the completion of primary assessment and resuscitation, and provides comprehensive information about various organ systems. So there is a trimodal peak of death in trauma. This is what I am saying about. The first peak occurs within seconds or minutes, and patients usually don't survive and they die on the, for example, laceration of the brainstem, heart, aorta, or large vessels, or penetrating injury to the heart. These are all the things which may instantaneously kill the patient. And salvage of the patient after this injuries is difficult, and victims mostly succumb instantaneously. The second peak occurs within minutes to hours, and this is the examples like subdural hematoma, pneumothorax, splenic laceration, life-threatening long bone injuries, or significant blood loss. This is the second peak, which is potentially at risk of death unless you immediately attend and salvage them. And if saved with aggressive and appropriate management, they can be the mortality can be prevented in these patients. And the concept of golden hour is mainly applied to the second peak group of patients. The third peak of death occurs several days to weeks after initial injury, mostly due to sepsis or multi-organ failure. So what they have contracted the infection that leads on, but they survive initial phase where they don't require any urgent treatment like what the second category belongs to. And the early management, we focus on ABC survey, and the basic principles are target the greatest threat to the life first. That is the first and foremost golden rule that you have to. For example, if the patient is having a massive bleeding because of external injury, and that is going to exsanguinate him and cause hypovolemia and death, first you attend to that. So any obvious greatest threat to the life should be attempted first, and lack of definitive diagnosis should not impede the application of indicated treatment. A detailed history is not a prerequisite. You don't have to ask any questions and get the history from this patient. And the main steps are primary assessment, resuscitation, and pre-assessment of airway breathing circulation, and then later on secondary assessment. Sorry, in the primary assessment, airway with inline cervical immobilization is the must. This is the first golden rule that we follow. So first make sure that the airway is patent by first assessing that. So if a patient is able to clearly speak and talk to you, it is a good indicator of a clear airway. So you don't have to worry about that. Whereas a noisy breathing indicates an airway obstruction. Patient semi-conscious or disoriented and he has a very noisy gurgling breathing. That means the patient's airway is obstructed. Either suctioning or a chin lift and jaw thrust should be done for keeping the patient airway intact and prevent any obstruction. In this juncture, an oropharyngeal airway may be required to maintain the patent airway, especially in obese patients where you cannot be holding the jaw for chin lift or jaw thrust for a long time. And if the initial measures are inadequate, like inserting the oropharyngeal airway or a chin lift or jaw thrust, effectively maintain the airway patency by early intubation. Don't wait to get in hypoxic and finally intubate. Early intubation is always necessary. And another indication for the endotracheal intubation is the risk of aspiration. The patient had a full stomach and then sustained the trauma. He is always in the risk of aspiration, or he has obtended conscious level. If GCS is low, then all these patients require intubation not possible. Either you intubate, otherwise straight away go for a surgical airway also. You can do a cricothyroidectomy. And in polytrauma patients, where altered level of consciousness with blunt injury is there, assume that always the patient has a cervical spine injury until otherwise proved. So all patients with facial and neck injuries or polytrauma, you have to assume that they may have a cervical spine injury and go for stabilization of the spine with mechanical support or manual support by inline stabilization. And the unintentional move of cervical spine should be minimized by the manual inline stabilization. So these are all the points to be added to airway maintenance in the initial phase. Then breathing with oxygen supplementation. So oxygenation should be started as early as possible. So oxygen is administered using a high flow, the reservoir bag to ensure high fraction of inspired oxygen concentration. Then you do an inspection, palpation, and auscultation of the patient's chest to find out whether there are any fractured ribs or pneumothorax or flail chest and all these things. And no chest wall movement indicates that patient may be having a spinal cord injury with only an abdominal breathing. And paradoxical chest wall motion will indicate that it may be a flail chest. So here in the golden hour, you have to use the examples of the clinical conditions also in the ABC survey, what you can expect. And the tension pneumothorax is another immediate killer, which has to be identified and treated as early as possible. And another thing is pneumothorax or open pneumothorax also will be there. So tension pneumothorax is a life-threatening condition and it should be immediately relieved by a nasal thoracostomy, and that will go a long way in making patients survive. And coming to the circulation with hemorrhage control, hemorrhage is a predominant cause of death in most of the trauma cases. So clinical parameters that provide information about the circulation are the pulse, neurological status, and blood pressure. And if there is obvious external bleeding, compression and external pressure should be applied, or even a tourniquet can be applied to minimize the bleeding. And if hypotension is present, you must give a fluid bolus of 1 to 2 liters of finger lactate as fast as possible to maintain the circulating volume. And the source of hemorrhage, especially occult hemorrhage inside the abdomen or thorax, can be identified first by a focused assessment of sonography for trauma. So that is the way to identify the internal hemorrhage. Or a CT scan should be done. And the fourth point, disability, is rapid neurological. You mainly concentrate on the neurological system because that is the one which will be involved in major trauma cases. So a rapid neurological evaluation should be done, and assess the DCS should be assessed. If it is less than 8, it should be automatically patient should be intubated, and expose the patient to see for the other injuries, and the examination of external genitalia and rectal examination is not included in the primary survey. It goes only into the secondary survey. So you look for any obvious injuries outside during the exposure. And by the end of the primary survey and resuscitation, what you should have achieved is airway established and well maintained, supplemental oxygen initiated, and patient's SpO2 is satisfactory, cervical spine is immobilized, and two large bore IV lines should have been started by this time, and they should have drawn blood sample for baseline investigations and cross match in case of hemorrhages, and external hemorrhage control should have been achieved, and if possible you should have had an ECG blood pressure laser to monitoring installed, and brief neurological examination completed and BCS assessed, and full exposure and environment control done. That is not keeping the patient all the time exposed and allowing him to go in for hypothermia. Then secondary assessment, which should also be done if time possible within the first hour after completion of the primary survey. And that will include a head-to-toe systematic and comprehensive evaluation of all the organs. And here, this is the time you can ask for a detailed history. And the mnemonic that will be useful during this time is the ample mnemonic. Do you know what are all the expansions for this ample? Dr. Kamal?
No, sir.
Have you heard of that? Okay. This is a very useful mnemonic that can be used in any emergency surgeries, even not only in trauma but also in any emergency that you come across in your future practice. A stands for allergies. M stands for medications, especially anticoagulants, insulin, or cardiovascular medication. P stands for previous medical or surgical history. L stands for last meal, that is the time solid intake, and E stands for events which lead to the mechanism of this injury. So this short history, these 5 points will be very useful in assessing, making a quick assessment. And the adjunctive secondary assessment, that once you have stabilized the patient with the ABC, then the secondary adjustments are a urinary catheter is vital for polytrauma to assess the urine secretion, which is an indicator of adequate circulating volume and blood pressure. So always polytrauma patients should have a catheter, urinary catheter inserted as early as possible. But the caveat here is make sure that there is no pelvic fracture, because pelvic fracture may have a rupture urethra, and trying to insert a catheter there, that will cause more trauma and bleeding. So ensure that there is no pelvic fracture and then insert a urinary catheter. Similarly, a nasogastric tube is also very important, but that should not be inserted in case of skull fracture or patients with nasal bleeding, because you may insert the catheter into the cranial cavity. So make sure there is no basal fracture, and if that is suspected, then the tube should be inserted only through the oral cavity. So instead of nasogastric tube, you make it orogastric tube, and you can aspirate, especially in full stomach patients, it will be very useful. And if available, obtain an ABG and hematocrit and PaO2 and degree of acidosis. And patient survival depends on the resuscitation done during the golden hour. And I have not included the 3 points mentioned by Dr. Kamal, that is the time duration of how to make the preliminary survey if the trauma site, then how soon the patient should be transported, and what is the intervention to be done, the time limit in the hospital. That point also can be added to this particular answer. Apart from that, I think this will be sufficient for this particular question.